Welcome. The BoreCore archive is a collection of slow, methodical recordings of technical processes and perfectly boring routines designed to help you relax and fall asleep. New procedures are added regularly, so don't forget to like and subscribe. Time to relax, close your eyes, and take it on down to Sleepy Town.
Welcome to a complete operational guide for the Polysomnography Technologist, or how to help strangers sleep while you definitely do not. You are a Polysomnography Technologist. This is your job title. It has 7 syllables, which means it is a good job title. You have not yet decided whether you enjoy your job. You have decided that it is interesting. These are 2 different things. Tonight, you will oversee the overnight sleep study of 1 or more patients. A sleep study, also called a polysomnography, or PSG, is a comprehensive recording of physiological data during sleep. You will measure brain activity, eye movements, muscle tone, heart rate, oxygen saturation, airflow, respiratory effort, snoring, and body position simultaneously for approximately 8 hours. You will do this while remaining awake. This is the central irony of your profession. You will spend the night helping other people sleep. Whether you find this interesting or merely tolerable says something about you as a person, but it is not our place to say what. The word polysomnography comes from the Greek poly, meaning many, the Latin somnus, meaning sleep, and the Greek graphia, meaning writing. It means, roughly, the writing of many things about sleep. This is an accurate description. You will write many things about sleep tonight. Most of them will be numbers. Your shift begins at 5 o'clock in the afternoon. It ends at 7 o'clock the following morning. This is 14 hours. At some facilities, your shift is 12 hours. At others, it is 10. Whatever your shift length is, it is longer than a standard workday, and most of it will occur after midnight. This is something you accepted when you took the job, presumably. Let us begin. You arrive at the sleep laboratory. The sleep laboratory is a clinical facility that resembles a moderately comfortable hotel, in the sense that there are beds in it, and a moderately uncomfortable hotel, in the sense that the walls are lined with monitoring equipment. You badge in through the security door. The security door makes a clicking sound when it unlocks. This is the most exciting sound you will hear until approximately 2 in the morning, when a patient's oxygen saturation drops below 88%, and the alarm sounds, which we will discuss in detail later. You proceed to the monitoring station. The monitoring station is a room adjacent to the patient rooms. It contains 1 or more computers, several monitors, a video display showing all patient rooms simultaneously, and a telephone. It also contains a chair in which you will spend most of your night. The chair is important. You should assess the chair. Is it supportive? Is it at the correct height? These are things that will matter at 3 in the morning. They do not matter as much at 5 in the afternoon. But this is when you have the attention available to think about them. You greet your colleagues, if there are any. At a large facility, you may work alongside another technologist or a supervisory sleep technologist. At a smaller facility, you may be alone. In either case, you say hello. You say hello in a normal way. The sleep laboratory, while quiet, does not require whispering during the pre-shift period. The patients have not yet arrived. No one is sleeping. This is the only time tonight when this will be true. You receive the handoff report from the day shift, if there is a day shift. Many sleep laboratories operate only overnight, in which case there is no day shift and no handoff report, only a set of patient files waiting for you. Either way, you review the following information. How many patients are scheduled tonight? What type of study each patient is having? Any relevant medical history flagged for the study, and whether any equipment was reported as malfunctioning during the previous study period. Equipment malfunctions are noted neutrally. You do not feel frustration at equipment malfunctions. You investigate equipment malfunctions with the same calm interest with which you approach everything else in the laboratory. This is because either the equipment can be fixed, in which case your calm was appropriate, or it cannot be fixed, in which case your frustration would not have helped either. Tonight, you have 2 patients. The first patient, whom we will call patient A, is scheduled for a diagnostic polysomnography. This means the purpose of the study is to determine whether patient A has a sleep disorder. Patient A is a 52-year-old who has been referred by their primary care physician for evaluation of suspected obstructive sleep apnea. Their bed partner reports witnessed apneas, pauses in breathing during sleep. Their Epworth Sleepiness Scale score, which is a standardized questionnaire that measures daytime sleepiness on a scale of 0 to 24, was 16. A score above 10 is considered to indicate excessive daytime sleepiness. 16 is, by this measure, noticeably above 10. The second patient, whom we will call patient B, is scheduled for a CPAP titration study. CPAP stands for continuous positive airway pressure. Patient B has already been diagnosed with obstructive sleep apnea during a previous study. Tonight, you will determine what pressure of air delivered through a mask, while patient B sleeps, will keep patient B's airway open. This is called a titration. You will adjust the pressure up and down throughout the night in response to patient B's breathing. This sounds like more than it is. It is also more than it sounds like. Both of these things are true simultaneously. You enter patient A's room first. A standard sleep laboratory patient room contains a bed, typically a full or queen size, made with clean linens. It contains a bedside table, a small dresser or closet area, and a bathroom. It is designed to approximate the feeling of sleeping somewhere other than a hospital room, while still being, unambiguously, a clinical room. There is monitoring equipment mounted to the wall or ceiling. There is a small infrared camera in the upper corner of the room, which you will use to observe the patient throughout the night without entering the room. There is a speaker and microphone system so that you can communicate with the patient, and the patient can communicate with you. You check the bed. The linens are clean. They were changed after the previous study. You verify this is true. It is true. You verify the pillow is present. One pillow. This is standard. Some patients will ask for additional pillows. You will accommodate this request if possible. Additional pillows do not meaningfully affect the quality of the polysomnography recording, but they can affect whether the patient is able to sleep, which is the entire purpose of what you are doing. Patients who cannot sleep do not produce useful data. This is a practical concern. You move to the equipment panel beside the bed or on the bedside table. This is the patient interface box, sometimes called the head box. All physiological signals from the electrodes you will apply to the patient run through wires that connect to this box, which then transmits the signals to the recording computer in the monitoring station. You inspect the head box. You verify all inputs are present and free of damage. There are typically inputs for EEG electrodes, EOG electrodes, EMG electrodes, ECG leads, a pulse oximeter, airflow sensors, respiratory effort belts, a position sensor, and a snore microphone. Each of these will measure a different thing. Together, they will measure everything. EEG stands for electroencephalography. This measures the electrical activity of the brain through electrodes placed on the scalp. The EEG is the most important channel in a polysomnography. It tells you what stage of sleep the patient is in. Without the EEG, you cannot stage sleep. Without staging sleep, you have not performed a polysomnography. You have merely watched someone breathe in the dark, which, while not without its merits, is not what anyone is paying for. EOG stands for electrooculography. This measures the electrical changes caused by eye movements. The eyes generate a small electrical potential difference between the cornea and the retina. When the eyes move, this potential difference shifts. You can detect this shift through electrodes placed near the eyes. Rapid eye movements, detected by EOG, combined with other signal characteristics, tell you when the patient has entered REM sleep. REM stands for rapid eye movement. It is the stage of sleep most associated with dreaming, though dreaming occurs in other stages as well, just less vividly and with significantly less narrative coherence. EMG stands for electromyography. This measures muscle activity. In a standard polysomnography, you will record EMG from the chin muscles, called the mentalis and submentalis muscles, and often from the anterior tibialis muscles of the legs. The chin EMG is important because muscle tone decreases dramatically during REM sleep. A loss of chin EMG tone, combined with rapid eye movements on EOG and specific EEG patterns, confirms REM sleep. If the chin EMG remains high during apparent REM, this may indicate REM behavior disorder, a condition in which patients physically act out their dreams, which is as interesting as it sounds, and significantly more concerning than it is interesting. Leg EMG is recorded to detect periodic limb movements, which are rhythmic, repetitive jerks of the legs that occur every 20 to 40 seconds during sleep. Many people have periodic limb movements. Many of them do not know it. You are about to find out whether patient A is one of them. You prepare the electrodes. Electrodes for polysomnography are small, cup-shaped metal discs, typically gold-plated or silver chloride, approximately 1 centimeter in diameter. They are filled with a conductive paste, typically 10-20 paste, which is a beige, slightly grainy substance that improves the electrical contact between the electrode and the skin. You will apply many of these electrodes tonight. We will discuss the exact placement and procedure in detail. There will be a great deal of detail. This is that kind of video. You also prepare the airflow sensors. There are 2 of these. The first is a nasal pressure transducer, a small prong-shaped device that sits just inside the nostrils and measures the pressure changes caused by breathing. The second is an oral nasal thermistor, a device that sits below the nose and detects the temperature change of exhaled air as it passes over it. These 2 sensors measure airflow in different ways and are complementary. The nasal pressure transducer is more sensitive. The thermistor is more reliable in detecting complete cessation of airflow. You use both. You prepare the respiratory effort belts. These are elastic bands that you will place around the patient's chest and abdomen. As the patient breathes, the chest and abdomen expand and contract. The belts detect this expansion and contraction. This allows you to determine whether, during an apnea, the patient is still trying to breathe, which would suggest an obstruction in the airway, or whether the respiratory drive itself has stopped, which would suggest a central apnea originating in the brain. This distinction is important. Obstructive sleep apnea is common. Central sleep apnea is less common. They are treated differently. Knowing which one the patient has is useful. You prepare the pulse oximeter. This is a small clip that attaches to the patient's finger and measures oxygen saturation in the blood by shining light through the fingertip. Oxygen saturation, expressed as a percentage and abbreviated SpO2, tells you how well the patient's blood is being oxygenated. In healthy individuals breathing room air, SpO2 is typically 95 to 100%. During apneas, when breathing stops, oxygen saturation falls. The degree and frequency of these falls is clinically meaningful. You will watch these falls tonight with professional attentiveness. You prepare the snore microphone. This is a small microphone that attaches to the front of the neck, over the larynx. It detects vibrations associated with snoring. Snoring is caused by turbulent airflow through a partially obstructed upper airway. It is not, in itself, diagnostic of anything, but its presence, frequency, and intensity are relevant to the overall picture. Patients who snore loudly are often surprised to learn this. Patients who share a bed with loud snorers are never surprised. You prepare the body position sensor. This is a small accelerometer that attaches to the patient's chest. It records whether the patient is lying on their back, their side, or their stomach. This is relevant because sleep apnea in many patients is positional, meaning it is significantly worse when the patient lies on their back, a position called the supine position. If the study shows that all of the patient's apneas occur in the supine position and none occur when the patient lies on their side, this is called positional obstructive sleep apnea. The treatment implications are different. Knowing is better than not knowing. In this context, as in most contexts, you set out all supplies on the equipment table. You do this in a systematic way. Electrodes, conductive paste, electrode remover wipes, gauze squares, tape, collodion if used at your facility, measuring tape, skin prep gel, cotton-tipped applicators, syringes with blunt tips for applying paste, each item in its place. The process of setting up is itself a kind of calibration, a way of ensuring that when the patient arrives, you will be able to move through the application procedure without searching for anything. Searching for things is inefficient. In a sleep study, inefficiency is measured in the patient's irritability, which has a direct inverse relationship to the quality of your evening. You set up patient B's room with similar care, adding the CPAP equipment. The CPAP machine sits on the bedside table. You check the machine. You attach the circuit, the machine, the humidifier chamber, the tubing, the mask. Tonight, patient B will wear a nasal mask based on their file notes from a previous study. You confirm the mask size. You set the starting pressure, which you will adjust throughout the night. You check the humidifier water level. You verify the machine's firmware is current. You record the machine's serial number. These are the kinds of things you do without thinking about doing them, which is to say, with very deep procedural thinking about doing them. You return to the monitoring station. You have 45 minutes before patient A is due to arrive. You open the patient file. Patient A's file contains a physician's order for the study, a completed intake questionnaire, a medical history, a list of current medications, and the scored Epworth Sleepiness Scale. You read all of these. Patient A reports falling asleep during conversations on several occasions. The Epworth Sleepiness Scale has 8 items, each rated 0 to 3, for a maximum score of 24. Patient A answered 3, the maximum, to the question about falling asleep while talking to someone. This is notable. most people find conversations stimulating enough to remain awake through it. Patient A does not, or did not, on the day they completed the questionnaire. Either way, this is clinically significant. Patient A's medications include a blood pressure medication, a proton pump inhibitor for acid reflux, and a mild antihistamine taken occasionally for allergies. None of these are expected to significantly affect the polysomnography recording, though antihistamines can suppress REM sleep in some individuals. You note this. You will remember it when you are looking at REM latency tonight. REM latency is the time from sleep onset to the first REM period. Normal REM latency in adults is approximately 90 minutes. A very long or very short REM latency is meaningful. Everything is meaningful. This is also the central burden of your profession. Patient A reports going to bed typically between 10:30 and 11 p.m., waking between 6 and 6:30 a.m., and feeling unrefreshed in the morning. They report waking multiple times during the night to use the bathroom. They report loud snoring confirmed by their bed partner. They report occasionally waking with a choking or gasping sensation. These are classic symptoms of obstructive sleep apnea. You have seen these symptoms described in many patient files. You read them with the same steady attention you bring to all patient files, including the ones that say something unexpected. Patient B's file shows a prior diagnostic study during which an apnea-hypopnea index, or AHI, of 47 events per hour was recorded, along with an oxygen saturation nadir, meaning the lowest recorded SpO2 of 79%. An AHI of 47 is severe. Normal is fewer than 5 events per hour. Anything above 30 is classified as severe. Patient B was diagnosed with severe obstructive sleep apnea and referred for CPAP titration. Tonight, you will find their optimal CPAP pressure. You approach this with professional resolve. You also note that patient B's file mentions a history of claustrophobia, which is relevant because CPAP requires wearing a mask over part of the face during sleep. This is something patient B is aware of and has agreed to attempt. You appreciate patient B's willingness to attempt things. You check the recording software. You open the polysomnography program on the monitoring station computer. You verify that the patient records are created and properly labeled. You verify that the signal channels are correctly configured. The EEG channels, the EOG channels, the EMG channels, the ECG channel, the respiratory channels, the SpO2 channel, the snore channel, the position channel. You verify the sampling rates. EEG channels are typically sampled at 200 to 500 Hz, meaning 200 to 500 measurements per second. This produces a great deal of data. Over the course of an 8-hour night, this is a very large amount of data. Computers handle this without complaint. This is one of the more reliable things about computers. You set your epoch length. An epoch is the unit of time in which sleep is scored. The standard epoch length in polysomnography is 30 seconds. Each 30-second epoch will be classified as either wake, N1, N2, N3, or REM when you or a scoring technologist review the study afterward. A typical night contains approximately 960 epochs. You will not score them in real time. You will monitor the study in real time and flag any events of interest. But the formal scoring is typically done after the study, either by you or by a dedicated scoring technologist. You will have enough to do tonight without scoring. You note the time. It is 6:55 p.m. Patient A is scheduled to arrive at 7 p.m. You have 5 minutes. You walk to the break room and pour yourself a cup of coffee. This is the first of several cups of coffee you will drink tonight. You are not proud of this, and you are also not ashamed of it. You are a polysomnography technologist working a night shift. Coffee is a professional accommodation. Patient A arrives at 7:03 p.m. Patients who arrive on time for a sleep study are pleasant surprises. Patients arrive late for sleep studies for several reasons, most of which are the same reasons anyone is late for anything. You greet patient A at the front of the lab. You introduce yourself by name and role. You explain briefly what will happen this evening. This is called the intake process, and it is important. A patient who understands what will happen to them tonight is more likely to tolerate the process calmly, and a patient who tolerates the process calmly is more likely to sleep. A patient who sleeps is what you need. This is a simple chain of causality. You walk patient A to the patient room. You show them the bathroom. You explain that they should shower or wash their hair tonight if they have not already, because oils and product in the hair can interfere with electrode contact. Patient A says they showered before arriving. Good. You note this. Clean hair means lower electrode impedance. Lower electrode impedance means cleaner signals. Cleaner signals mean more accurate staging. Everything connects. You hand patient A a patient gown or explain that they may sleep in their own comfortable clothing. Some labs require standard gowns. Some allow personal clothing. Your facility allows personal clothing for the upper body, but requires the patient to wear loose-fitting shorts or pajama bottoms for ease of electrode placement on the legs. Patient A nods. Patient A appears calm. This is good. Anxious patients have elevated cortisol, which can affect sleep onset and architecture. You do not explain this to patient A because explaining it would increase patient A's cortisol. You complete the intake questionnaire verbally, reviewing the document patient A already submitted and confirming any changes. You ask, have you consumed any alcohol today? Patient A says no. Good. Alcohol suppresses REM sleep and causes an artificial shift in sleep architecture. You ask, have you consumed any caffeine in the past 4 hours? Patient A says they had a cup of coffee at lunch, around noon. This is acceptable. 7 hours of caffeine clearance is generally sufficient. You ask, have you taken all of your regular medications today? Patient A says yes. You ask, are you feeling sick, congested, or experiencing any unusual pain tonight? Patient A says no. You note all of this. You review the consent form. With patient A, the consent form describes the study procedure, the sensors that will be applied, the fact that video monitoring will occur throughout the night, and the patient's right to discontinue the study at any time. Patient A reads the consent form. You wait while patient A reads. Patient A signs the consent form. You countersign. You place the form in the patient record. This is a regulatory requirement. You follow it not because you are required to, but because you understand why it exists. Both of these are true. You explain the electrode application process, that you will place several sensors on the scalp face and body, that this will take approximately 45 to 90 minutes, that it is not painful, that it is somewhat time-consuming, and that the end result will be that the patient appears to be wearing a substantial quantity of wiring. You pause here and allow patient A to absorb this. Patient absorbs it. They have been told to expect this. The photographs on the patient information brochure were informative or alarming, depending on the patient. Patient B arrives at 7:15. Patient B is also on time. You check on patient B briefly and introduce yourself, explaining that you will complete their room setup and begin their hookup after patient A is settled. Patient B says they understand. Patient B appears anxious. You note this and make a mental note to take extra time during patient B's mask fitting. You return to patient A's room. Patient A is seated in the bedside chair, wearing their sleep clothing. You pull the electrode supply tray close. You are ready to begin the hookup. First, you will measure the patient's head. This is done using a flexible measuring tape and follows the International 1020 system of electrode placement, a standardized method developed in the 1950s by Herbert Jasper, which remains the standard for EEG electrode placement today. The name 1020 refers to the fact that electrodes are placed at positions 10 and 20% of the total distance between specific skull landmarks. This is a very organized system. You will now use it. You identify the nasion. The nasion is the bony indentation at the top of the nose, just between the eyes. You press gently on this point. You identify the inion. The inion is the bony protrusion at the back of the skull, midway up, where the neck muscles meet the skull. You press gently on this point. The patient does not object to this because it is not painful, and because you have explained that you will be measuring their head. You measure the distance from the nasion to the inion over the top of the skull. For a typical adult, This is approximately 36 centimeters. You record this number. 10% of this distance is approximately 3.6 centimeters. This is the distance from the Narration to FPZ and from the Inion to Oz. 20% of this distance is approximately 7.2 centimeters. You continue calculating and marking positions along the sagittal midline from front to back. Next, you measure from one preauricular point to the other. The preauricular point is the notch in front of the ear, just above the tragus. You measure across the top of the skull from left preauricular point to right preauricular point. You record this measurement. You find 10% and 20% intervals along this axis as well. Where the sagittal midline and the coronal midline intersect is the vertex, the top of the head, the position designated CZ. You mark the scalp at each electrode position using a grease pencil or a washable skin marker. The positions you will use for this standard diagnostic PSG are F4, C4, O2, and M1 on the right side, and F3, C3, O1, and M2 on the left side. You also mark the EOG positions above and outside the outer canthus of the right eye and below the outer canthus of the left eye. These are not on the scalp, but you mark them now for reference. You pick up the first electrode. You part the patient's hair at the marked scalp position. You use a cotton-tipped applicator dipped in skin prep gel to abrade the scalp gently at the site. The skin prep gel contains a mild abrasive that removes the outer layer of dead skin cells, reducing skin resistance and improving electrode contact. The patient feels mild friction. You explain what you are doing. The patient nods. You fill the electrode cup with 10-20 conductive paste. 10-20 paste is a beige, thick substance that looks somewhat like a very dense hand lotion. It is not hand lotion. Its purpose is to provide a conductive medium between the electrode and the scalp. You apply the paste-filled electrode to the scalp at the prepared position. You hold it firmly for a moment, and then secure it with either collodion or a piece of gauze and adhesive tape, depending on your facility's protocol. Collodion is a liquid adhesive that dries rapidly and holds the electrode firmly in place for the duration of the study. When using collodion, you apply it around the electrode with a cotton-tipped applicator, then briefly blow air through a small squeeze bulb to accelerate drying. The dried collodion forms a firm, clear seal around the electrode. It works extremely well. It also smells distinctly of acetone. The patient often notices this. You explain that it is a medical adhesive and that it is not harmful. This is true. The smell dissipates as it dries, not entirely, but substantially. You apply the F4 electrode. You apply the C4 electrode. You apply the O2 electrode. Each application follows the same sequence. Part hair, prep skin, fill electrode, place electrode, secure electrode. The sequence is meditative if you allow it to be. Many technologists find the hookup process to be one of the more calming aspects of the job. In the same way that any repetitive, skilled task becomes meditative through repetition. This may or may not be true for you. This is a personal matter. You check the electrode leads, the thin wires connecting each electrode to the longer cable bundle that will attach to the headbox. The leads should be neatly arranged, not tangled, lying flat against the scalp, and secured lightly with additional tape where needed. A tangled lead bundle is a nuisance. It is not a crisis. It is a nuisance. You move to the left side. You apply F3. You apply C3. You apply O1. You repeat. Part hair, prep skin, fill electrode, place electrode, secure electrode. The patient sits with the patience of someone who was warned this would take a while and has decided to accept this. This is the correct response. You appreciate it. You apply the reference electrodes at the mastoid processes. The mastoid process is the bony prominence behind the ear. These are the M1 and M2 positions, also called A1 and A2, and they serve as reference points against which many of the EEG signals are measured. A single channel of EEG does not simply record electrical activity at one location. It records the difference in electrical potential between 2 points. The EEG you record at C4, for example, is recorded relative to M1. This derivation reduces artifact. If both the electrode at C4 and the electrode at M1 detect the same artifact simultaneously, the artifact cancels out of the signal. This is called common mode rejection. It is one of the more elegantly practical concepts in clinical neurophysiology, and you do not think about it consciously anymore because you have internalized it completely. The mastoid positions are behind the ears, over skin rather than hair. This makes them somewhat simpler to apply. You prep the skin behind patient A's right ear, fill the M1 electrode, and secure it with tape. You do the same behind the left ear. M2 is applied. You now have 8 scalp and reference electrodes in place. The patient's head is beginning to accumulate hardware. This is expected. You are approximately 40% finished with the hookup. You proceed to the eye electrodes. The EOG electrodes detect eye movements. For standard polysomnography, you will place one electrode above and slightly to the right of the right eye, and one electrode below and slightly to the left of the left eye. This offset placement means that horizontal eye movements, including the rapid eye movements of REM sleep, produce opposite deflections in the 2 channels. When the eyes move right, for example, one electrode sees the positive pole of the cornea approaching, and the other sees it receding. The signals go in opposite directions. This out-of-phase relationship is one of the identifiers of genuine eye movements as opposed to artifact. An artifact affects both channels in the same direction. Eye movements affect them in opposite directions. This is how you know the difference. You prep the skin above the right eye, lateral to the midpoint. You apply the electrode. You prep the skin below the left eye, lateral to the midpoint. You apply the electrode. You secure both with tape. The patient blinks naturally during this process. You work around the blinks. You move to the chin EMG electrodes. Chin EMG requires 3 electrodes, 2 active electrodes placed on the chin muscles, and 1 ground electrode. The 2 active electrodes are placed below the lower lip, 1 at the midline, and 1 approximately 2 centimeters lateral, and the third is placed above the chin. Standard AASM guidelines specify the mentales and submentales placement. You prep the skin at each site. The skin on the chin has different characteristics from scalp skin. It is smoother. It still requires preparation. You prep and apply all 3 chin electrodes. You move to the leg EMG electrodes. For standard leg monitoring, you place 2 electrodes on the anterior tibialis muscle of each leg. The anterior tibialis runs along the front of the lower leg, beside the shin bone. You locate it by asking the patient to flex their foot upward toward the shin. The muscle belly contracts visibly. You mark the upper third of the muscle on both legs. You prep and apply the electrodes. You secure them with tape and a length of self-adhesive wrap to prevent them from shifting during the night. The patient is now wearing electrodes on their scalp, face, chin, and legs. This is progress. You apply the ECG electrodes. Electrocardiography during polysomnography typically uses a single modified lead configuration, using 2 electrodes placed subclavicularly, below the collarbone on each side. This configuration captures the heart rhythm well enough for clinical purposes during sleep, which does not require the diagnostic precision of a formal 12-lead ECG. You place a pre-gelled ECG electrode below patient A's right clavicle and another below the left clavicle. You connect the leads. You will check the ECG trace quality when you verify signals at the monitoring station. You attach the pulse oximeter to the patient's left index finger. The clip device slides on easily. You verify that the probe light is correctly positioned across the fingertip. The waveform will be visible on the monitoring screen once the system is running. You note which finger you used. This is recorded in the technical notes. You fit the respiratory effort belts. The thoracic belt goes around the chest at approximately nipple level. The abdominal belt goes around the abdomen just below the navel. Each belt has a sensing element that detects dimensional changes during breathing. You adjust the belts so they are snug, but not constrictive. A belt that is too loose may not detect subtle changes in respiratory effort. A belt that is too tight is uncomfortable and will cause the patient to shift position repeatedly throughout the night, generating artifact The correct tension is somewhere between too loose and too tight. This is, in one sense, a metaphor for many things. In another sense, it is literally a rubber belt around someone's midsection, and you adjust it accordingly. You attach the airflow sensors. The nasal pressure transducer prong is positioned just inside the nostrils. This is the part of the hookup that patients most frequently describe as unusual. You explain what it is and why it is there. Patient A accepts this with equanimity. You secure the tubing with a small piece of tape on each cheek, routing it back behind the ears and down to the headbox cable bundle. The oral nasal thermistor is positioned below the nose, its sensing elements in front of the mouth and nose. It is also secured with tape. The patient now has sensors under and inside their nose. They are adapting. You attach the snore microphone to the front of the throat, over the laryngeal prominence. This is secured with a small piece of medical tape. You explain that this will detect snoring vibrations, and that it is not measuring the content of anything the patient might say. Patients sometimes ask this. Patient A does not ask this. You attach the body position sensor to the center of the chest with a strip of adhesive medical tape. You verify that it is oriented correctly per the labeling on the device, so that the positions it records correspond accurately to the patient's actual position. You gather all the electrode leads and sensor cables into a single organized bundle and connect them to the headbox. Each connector is labeled. You match each to its corresponding input on the headbox. You do this in a systematic order: EEG leads, EOG leads, chin EMG leads, ECG leads, leg EMG leads, respiratory leads, auxiliary sensors. You connect each one. You verify each connection is seated firmly. A loose connection will produce artifact or signal dropout. Either is preferable to no connection, but neither is preferable to a good connection. You drape the cable bundle over the edge of the bed. There is enough slack that the patient can move normally during sleep without pulling at any sensor. You verify this by asking the patient to turn to their left side. The cables move with them. No sensor pulls. No lead dislodges. Good. You help patient A into bed. They sit, then recline. You arrange the cable bundle so that it rests comfortably. You remind them that if they need to get up during the night, they should call you through the intercom, rather than disconnecting sensors and walking. Because walking while connected to the headbox without disconnecting properly can pull sensors from the body and cause both signal disruption and, in theory, a mild inconvenience. Patient A is in bed. It is 8:50 p.m. You excuse yourself and go to the monitoring station to check signal quality. You sit at the monitoring station. Patient A's signals are displayed across the screen in horizontal traces. You evaluate each trace. Electrode impedance must be checked first. Impedance is the opposition to the flow of electrical current through the electrode-skin interface. Lower impedance means better signal quality. The AASM recommends that scalp electrode impedance be below 5 kilohms, though up to 10 kilohms is generally acceptable in clinical practice. You run the impedance check through the recording software. Numbers appear for each electrode position. F4, 3 kilohms, C4, 4 kilohms, O2, 6 kilohms, F3, 3 kilohms, C3, 5 kilohms, O1, 7 kilohms, M1, 2 kilohms, M2, 2 kilohms. The right occipital electrode, O2, is at 6 kilohms, which is acceptable. The left occipital electrode, O1, is at 7 kilohms, which is borderline. You will monitor this channel. If it produces excessive artifact during the recording, you may need to reprep and reapply the electrode during the night. For now, it is acceptable. You check the EEG traces. Patient A is awake and sitting up in bed. The EEG should show alpha rhythm, which appears as regular sinusoidal waves at 8 to 13 cycles per second, most prominent over the posterior electrodes, O1 and O2. You look at the occipital channels. There is a clear rhythmic pattern. You count the cycles, approximately 10 per second. This is a normal alpha rhythm. Patient A has a brain that is doing what brains do when they are awake and resting. This is a good sign. You check the EOG. Patient A's eyes are open. The EOG shows slow, rolling movements, which is typical. You will ask patient A to perform the biocalibration sequence momentarily. You check the chin EMG. There is a moderate level of activity, consistent with a relaxed but awake state. The signal is clean, and there is no significant artifact. You check the ECG. There is a clear, regular waveform. The rate appears to be approximately 70 beats per minute. The morphology looks normal. The ECG is not a diagnostic instrument in this context, but severe arrhythmias would be visible, and you would note them. You check the leg EMG. Both leg channels show low, stable activity, which is appropriate for a relaxed, seated position. The signal is clean. You check the respiratory channels. The airflow sensors are showing appropriate waveforms with each breath. The nasal pressure transducer shows a slightly irregular pattern, which is normal for resting, awake breathing. The thermistor shows a similar pattern. The respiratory effort belts show regular thoracic and abdominal excursions in phase with each other, which indicates normal breathing effort. You check the SpO2. 97%. Normal. You activate the intercom. You explain to patient A that you would like them to perform a brief series of movements so that you can verify all sensors are recording correctly. This is called the biocalibration, and it takes approximately 3 to 5 minutes. You instruct patient A to look straight ahead and blink 5 times slowly. Patient A blinks. The EOG channels deflect with each blink, confirming that the eye channels are recording. You note this in the technical log. You instruct patient A to look to the right without moving their head. Patient A looks right. The EOG channels deflect in opposite directions, consistent with a rightward eye movement. You note this. You instruct patient A to look to the left. Patient A looks left. The EOG channels deflect in opposite directions again, now reversed from the rightward deflection. This is correct. You instruct patient A to close their eyes and relax. After a few seconds, you can see the alpha rhythm increase in prominence over the occipital channels. Patient A is generating alpha with eyes closed. This is what brains do. You note this. You instruct patient A to hold their breath for 10 seconds. The airflow channels become flat. The respiratory effort belts continue to show effort because patient A is attempting to hold their breath, which requires respiratory muscle engagement. When patient A resumes breathing, the airflow channels show a deeper breath as they recover. You note this. The breath-holding maneuver verifies that the airflow sensors correctly respond to apnea-like events. You instruct patient A to grit their teeth twice. Patient grits. The chin EMG channels spike with each gritting. The electrodes are recording muscle activity. Good. You instruct patient A to dorsiflex their right foot, meaning to pull the toes upward toward the shin 3 times. The right leg EMG channel shows 3 discrete spikes. You instruct the same for the left foot. 3 spikes in the left channel. Both leg EMG channels are functional. You instruct patient A to simulate snoring by making a brief snoring sound. This is the biocalibration instruction that generates the most varied responses from patients. Some patients comply without comment. Some patients laugh. Some patients attempt a snoring sound and are dissatisfied with it. Patient A makes a brief, somewhat restrained snoring sound. The snore microphone channel deflects. Good. You instruct patient A that the biocalibration is complete, that all sensors are working correctly, that lights out will be at 10 p.m., and that in the meantime, they may read quietly or watch television at a low volume. You ask if they need anything. Patient A says no. You proceed to patient B's room. Patient B's hookup and biocalibration follow the same process, with the addition of the CPAP equipment. The CPAP mask fitting requires additional time and care. Patient B's history of mild claustrophobia means that the mask must fit well, be introduced gradually, and be explained thoroughly. You take this time. You have it. Patient B's mask is a nasal mask covering only the nose. You fit the mask cushion. Adjust the headgear straps so the mask seals without excessive pressure, and turn on the CPAP machine at a low pressure to allow patient B to acclimate. The sensation of continuous positive airway pressure is unusual at first. It feels like breathing against mild resistance because it is breathing against mild resistance. You explain this. You wait. Patient B acclimates. Their breathing settles into a new rhythm. You begin the biocalibration. Patient B's biocalibration proceeds normally, with the addition of noting the CPAP mask seal. If air is leaking audibly from the mask, the seal is insufficient and must be adjusted. Small leaks are tolerable. Large leaks reduce the effectiveness of the therapy and also produce a sound that patients find disruptive to sleep. You verify the mask seal. It is adequate. You return to the monitoring station. It is 9:45 p.m. You have 15 minutes until lights out. You use this time to verify that the recording software is capturing all channels correctly, that the video monitors are functioning, and that both patient rooms are visible, and that your logbook is current. You activate the intercom to patient A's room at 10 p.m. You tell patient A that it is time for lights out, that they should try to get comfortable and go to sleep, that you will be monitoring throughout the night from the station next door, and that if they need anything, they should press the call button or simply speak, and you will hear them through the microphone. Patient A says goodnight. You say goodnight. You switch off the lights in patient A's room remotely. The room transitions to darkness. On your video monitor, the infrared camera illuminates the room in the gray-green light that infrared produces, making patient A visible as a pale, slightly ghostly figure settling into the bed. You activate the intercom to patient B's room and repeat the process. Patient B says goodnight. You say goodnight. Patient B's CPAP machine hums steadily. This is normal. The hum of the CPAP machine is the sound of adequately oxygenated sleep being attempted. You note the lights out time in your technical log. This is the start time of the recording period. The clock for sleep latency calculation has begun. You settle into your monitoring station chair. You look at the screens. 2 rows of signal traces scroll steadily from right to left. Each channel its own line, each line representing something that is happening inside 2 sleeping or trying to sleep human bodies. You watch. The first few minutes after lights out are often the most restless. Patients who have been told to sleep do not always immediately sleep. This is not a failure. It is biology. The brain does not transition from wakefulness to sleep on command. It transitions on a gradient through a series of physiological changes that you can observe on the screen. You watch patient A's EEG. The alpha rhythm, which was clear during the biocalibration, is now intermittent. Alpha disappears when the eyes close and the patient relaxes, then reappears when they shift or briefly open their eyes. Each disappearance is a small step toward sleep. At 10:17 p.m., the alpha rhythm becomes sparse. The EEG begins to show a different pattern, lower amplitude, mixed frequency activity. The eye channels show slow, rolling movements, different from the sharp deflections of voluntary eye movements. The chin EMG is lower than during wakefulness. This is N1 sleep. Stage N1 is the lightest stage of sleep, the transitional stage between wakefulness and sleep. It typically occupies approximately 5% of total sleep time. It is easy to enter and easy to exit. A noise, a shift in body position, or an apnea can return the patient to wakefulness from N1 within seconds. You note the time of the first epoch scored as N1, 10:17 p.m. Lights out was 10 p.m. Patient A's sleep latency is 17 minutes. This is within the normal range. Normal sleep latency is typically under 20 minutes. You watch. N1 continues for approximately 4 minutes. At 10:21 p.m., the EEG changes again. The low amplitude, mixed frequency pattern gives way to something new. You see a brief burst of rhythmic, 13 Hz spindle-shaped activity lasting approximately 1 second. This is a sleep spindle. Sleep spindles are one of the defining features of N2 sleep. Seconds later, you see a K-complex, a large, sharp negative deflection in the EEG, followed immediately by a positive component, standing out clearly against the lower amplitude background. K-complexes are also defining features of N2, with the first K-complex, or sleep spindle, in the absence of alpha rhythm. You are now in N2. You note the time. N2 is the most abundant sleep stage in adults, typically comprising 45 to 55% of total sleep time. It is deeper than N1, but not the deepest stage. Patients awakened from N2 often recall brief, fragmented thought rather than vivid dreams. The content of N2 thought, when recalled, tends to be mundane. Patients report thoughts about lists, conversations, tasks. This makes N2 sleep the most productive stage for this particular video. You continue watching. At 10:23 p.m., patient A moves. The movement is a brief shift in body position from supine to left lateral. The position sensor logs this. Several electrodes produce a burst of artifact from the movement. The movement itself takes approximately 2 seconds. The EEG is disrupted during this movement, which is expected. After the movement, patient A resettles. The EEG returns. Patient A is still in N2. The movement was not an arousal in the technical sense. A technical arousal is defined by the AASM as a return to alpha rhythm on EEG lasting at least 3 seconds during NREM sleep. This movement produced brief artifact, but not sustained alpha. Patient A did not wake up. They shifted. This happens. You continue watching. The channels scroll. Spindles appear and disappear at their intervals, like small organized events in an otherwise even landscape. K-complexes appear occasionally. Patient A's breathing, visible on the airflow and effort channels, has slowed and regularized. At 11:04 p.m., patient A enters N3. N3 is deep, slow wave sleep, sometimes called delta sleep. The EEG transitions from the moderate amplitude, mixed frequency background of N2 to high amplitude, low frequency waves. Delta waves are defined as having a frequency below 2 Hz and an amplitude above 75 microvolts. When more than 20% of a 30-second epoch is composed of delta waves, the epoch is scored as N3. The delta waves of N3 are remarkable in that they look so different from waking EEG. They are large. They are slow. They are powerful. They represent the deepest sleep most people will get tonight. Patient A's brain, in generating these waves, is doing something essential. The exact functions of slow wave sleep include memory consolidation, glymphatic clearance of metabolic waste from the brain, physical restoration, and hormone regulation. Deep sleep is not doing nothing. It is doing many things at once. You observe this process while doing your own things, which are also several. During N3, you check patient A's respiratory channels. The breathing continues, regular and deep. The SpO2 is 96%. Normal. No events yet. You check patient B. Patient B has taken longer to fall asleep, which is not surprising given the mask and the history of claustrophobia. At 10:58 p.m., patient B's EEG shows the first sleep spindle. Sleep latency, 58 minutes. Long, but acceptable. You note this. At 11:30 p.m., patient A's respiratory channels change. The airflow, which has been regular, becomes irregular. You watch. A breath occurs, then a pause. The airflow channels go flat. The nasal pressure transducer reads 0. The thermistor reads 0. The respiratory effort belts continue to show effort. The chest and abdomen are still trying to breathe. The body is making the right motions. The air is not moving. This is an obstructive apnea. The airway has collapsed. You begin counting. 1 second, 2 seconds. The effort continues. 5 seconds. The SpO2 begins to fall slowly as the oxygen in the bloodstream is depleted without replenishment. 10 seconds. The apnea duration threshold is 10 seconds. This is now a scorable apnea. 15 seconds, 20 seconds, 25 seconds. At 26 seconds, the airflow channels reactivate abruptly. Patient A takes a breath. The breath is deeper than usual, a compensatory breath to restore oxygen and clear carbon dioxide. On the EEG, there is a brief shift to higher frequency activity, a possible arousal. You examine the epoch. Yes, the EEG shows approximately 4 seconds of alpha range activity following the termination of the apnea. This is scored as an arousal associated with the respiratory event. Patient A did not wake up. They may have had a partial arousal, a brief interruption of sleep that restored enough muscle tone to reopen the airway. They will not remember this. This is the nature of obstructive sleep apnea. The patient is repeatedly awakened or partially awakened by their own obstructed breathing. They sleep. They stop breathing. They wake just enough to breathe again. They return to sleep. This happens throughout the night. They wake in the morning feeling unrefreshed because they have spent the night in a cycle of sleep fragmentation they are entirely unaware of. You log the event. Time, duration, associated SpO2 drop, associated arousal, channel data. You continue watching. Over the next hour, you log additional events. Apneas, hypopneas, arousals. A hypopnea is different from an apnea. An apnea is a complete cessation of airflow. A hypopnea is a reduction of airflow by at least 30% compared to baseline, lasting more than 10 seconds, and associated with either an oxygen desaturation of at least 3% or an arousal. The distinction matters. Both contribute to the AHI. The AHI will determine the severity of patient A's diagnosis. At midnight, you check patient B's CPAP pressure. Patient B has been sleeping reasonably well, but you have already observed 2 breakthrough apneas at the starting pressure. You increase the pressure by 1 centimeter of water. 1 centimeter. You wait and watch. The next 15 minutes show no apneas. Good. The increased pressure appears to be working. The hours between 1 and 4 in the morning are the quietest hours in the sleep laboratory, which is to say, they are quiet in the way that a room full of physiological monitoring is quiet. The signals still scroll. The patients still breathe. You still watch. At 1:13 a.m., patient A enters REM sleep for the first time. REM sleep has a distinctive polysomnographic appearance. The EEG shows a low amplitude, mixed frequency pattern that resembles the wakefulness pattern more than it resembles N2 or N3. This is sometimes described as a desynchronized EEG because the high amplitude, organized slow activity of deep sleep has given way to lower amplitude, faster, more variable activity. The EOG shows bursts of rapid eye movements, sharp, irregular deflections that appear in opposite directions simultaneously in the 2 EOG channels, reflecting the eyes darting back and forth behind closed lids. The chin EMG shows very low tone, reflecting the physiological atonia of REM, the muscular paralysis that prevents you from acting out your dreams. You watch the eye movements, bursts of rapid movements, then nothing, then another burst. The movements are erratic, unpredictable. They are nothing like the slow, rolling movements of N1. They are brisk, random, energetic in the way that activity during sleep can only be because the person is entirely unaware of them. Patient A's REM latency, meaning the time from the first epoch of sleep to the first epoch of REM, is approximately 102 minutes. This is within the normal range for an adult. Normal REM latency is approximately 90 minutes, with normal variation between about 60 and 120 minutes. During REM sleep, you notice that patient A's respiratory events become more frequent. This is common in obstructive sleep apnea. The muscle atonia of REM extends to the muscles of the upper airway, making the airway more collapsible. Patients with OSA often have their worst breathing during REM sleep. You log additional events. The SpO2 is dropping more frequently and more deeply than during NREM. You note the nadir SpO2 for each event: 89%, 87%, 85%. Each event is logged. The AHI during REM will be calculated separately from the overall AHI because many patients have isolated REM-related OSA. At 1:55 a.m., patient A moves significantly in bed, shifting from lateral to supine. The position sensor logs the change. Almost immediately, the frequency of apneas increases. When patient A was on their side, the airway was partially supported by positional factors. Supine, the tongue and soft palate fall posteriorly under gravity, narrowing the airway further. You note this in the technical log. The positional data will be relevant to treatment planning. You check in on patient B. Patient B is sleeping on their side, CPAP running. The breathing is regular. The SpO2 is 96%. No apneas in the last 30 minutes. You increased the pressure once earlier in the night. It appears to be sufficient. You make a note and continue monitoring. At 2:30 a.m., you conduct your scheduled environmental check. This involves walking briefly to each patient room, not entering unless necessary, and visually confirming through the small window in the door or via the video monitor that the patient is in bed, appears comfortable, and that no sensor has visibly dislodged. Both patients appear comfortable. Both are asleep. This is the part of the night that requires a particular quality of attention. You are tired in the way that anyone working through the night is tired, which is a real tiredness that you manage through training, coffee, and the professional responsibility of understanding that what you are watching matters. Patients do not know that their SpO2 dropped to 85% at 2:18 a.m. They will not know until the study is scored and reviewed by the sleep physician. What you do tonight is the basis for what they will know. This is not something you need to romanticize. It is simply true. At 3 a.m., patient A's N3 sleep has largely ceased. This is expected. Deep, slow-wave sleep is concentrated in the first half of the night. As the night progresses, NREM sleep becomes lighter, and REM periods become longer and more frequent. Patient A cycles between N2 and REM. The EEG alternates between the moderate amplitude N2 pattern with spindles and K-complexes and the low amplitude mixed frequency pattern of REM with its bursts of eye movements. At 3:17 a.m., patient B wakes briefly. You can see this on the EEG, which shifts to wakefulness pattern, and on the video monitor, where patient B adjusts their mask. They do not call you. They readjust, resettle, and within approximately 8 minutes, sleep spindles reappear on the EEG. Patient B is asleep again. You log the wake period. You drink another cup of coffee. It is 3:43 a.m. This is the hour that is most approximately the center of the Earth's shadow, or at least feels that way, in the way that the most complete darkness of a night is felt rather than measured. You are aware of being tired. You are more aware of what you are watching. These coexist. At 3:51 a.m., something different happens in patient A's leg EMG channels. A spike appears in the right leg channel. 24 seconds later, another spike. 22 seconds after that, another. You watch. The pattern continues. A brief, discrete burst of leg muscle activity every 20 to 25 seconds, regular as a clock, occurring during N2 sleep. This is the pattern of periodic limb movements. You count the movements over a 5-minute segment. At least 5 periodic limb movements per hour constitutes a clinically notable periodic limb movement index. You count. You will calculate the total PLM index after the study. For now, you log the start time and note the channel and the regularity. Patient A did not tell you about restless legs or leg movements during sleep. This is not unusual. Periodic limb movements often go undetected by the patient. They may be reported by a bed partner, or they may be entirely unnoticed by everyone until a polysomnography detects them. Patient A's bed partner reported snoring, choking, and witnessed apneas. They did not mention leg movements. This is fine. This is what the study is for. The final 2 hours of the monitoring period are the REM-richest hours of the night. The pressure to sleep is lower now. The homeostatic drive that builds with each hour of wakefulness has been partially discharged by the sleep that has already occurred. The circadian rhythm has not yet begun its morning wake drive. The brain defaults to REM. Patient A is in a long REM period that began at 3:44 a.m. and continues into the 5 o'clock hour. 56 minutes of REM. This is a long REM period. Long REM periods in the second half of the night are normal and expected. The longer a REM period, the more vivid and narratively complex the dreaming, generally speaking. Patient A is, in all probability, experiencing a very coherent dream. It will be gone by morning. This is also normal. You observe the EOG channels. Bursts of rapid eye movements punctuate the REM period at irregular intervals. Physiologically, eye movements during REM are associated with scene changes in the visual cortex. Though the exact relationship between eye movements and dream content remains incompletely understood. This is, in the larger context of sleep research, one of many things that remain incompletely understood. The brain generates a great deal of activity during sleep that is observed, but not yet fully explained. You are contributing to the raw data that, aggregated across thousands of patients in labs like this one, slowly advances the science. This is meaningful. It is also very quiet. At 4:42 a.m., patient B's CPAP flow trace shows a sudden large leak. The CPAP machine's pressure has fluctuated and the mask seal has broken. You activate the intercom gently. You speak quietly because patient B is in REM sleep and a sudden loud noise would cause an arousal, which you want to minimize. You say patient B's name softly. Patient B stirs. You ask them to adjust their mask. Patient B adjusts. The leak resolves. Patient B settles back toward sleep. On the EEG, the REM pattern returns within approximately 7 minutes. You log the event. At 5:15 a.m., patient A's SpO2 drops to 82% during a prolonged apnea in the supine position. This is the lowest SpO2 of the night. You note the time, the event duration, and the SpO2 nadir in your log. Patient A arouses briefly from the apnea. The EEG shifts to wakefulness for approximately 12 seconds, then returns to N2. Patient A does not wake up. They do not know. They are breathing again. By 5:45 a.m., both patients are in lighter sleep. Patient A has shifted between brief N2 epochs and periods of wakefulness. Patient B is in N2. The overnight sleep architecture is drawing toward its natural morning conclusion. The homeostatic drive to sleep has been largely satisfied. The circadian rhythm is beginning its morning phase, promoting wakefulness. In approximately 15 minutes, you will initiate lights on. You begin preparing your technical notes for the end of the study. You review your logged events. Patient A, total recorded respiratory events to be calculated for AHI multiple SpO2 desaturations. Periodic limb movements beginning at 3:51 a.m. Sleep architecture showing N1, N2, N3, and REM all present. No significant EEG abnormalities. Patient B, successfully treated with CPAP at the determined pressure, with residual AHI low and SpO2 maintained above 90% for the majority of the night. One mask leak episode resolved with minimal disruption. At 6 a.m., you activate the intercom to patient A's room. You speak in a normal, calm voice. You say good morning. You tell patient A that the recording time is complete, that you will be coming in to remove the sensors, and that they may sit up when they are ready. Patient A responds. Their voice is the voice of someone who has just woken up, which is to say, it is slightly thick and imprecise. This is normal. The transition from sleep to wakefulness involves a period called sleep inertia, during which cognitive function and alertness are temporarily impaired. Sleep inertia typically resolves within 15 to 30 minutes. Patient A will feel more awake by the time they have showered, which you will encourage them to do before leaving, because the electrode paste and collodion will still be in their hair and on their face. You enter patient A's room. You turn on the room lights. Patient A is sitting up in bed. They look like a person who has slept in a laboratory with sensors attached to their body, which they are. You proceed with electrode removal. You begin removing the sensors in the reverse order of application. This is not an absolute requirement, but it is an efficient convention. You remove the body sensor, the respiratory effort belts, the ECG electrodes, and the leg EMG electrodes first. These are secured with tape and self-adhesive wrap. You peel the tape gently, pressing the skin down near the tape edge to reduce tension. Tape that has been on skin for 8 hours has had time to bond well. You are slow about this. Ripping tape off skin is both unpleasant for the patient and unnecessary. You remove the airflow sensors. The nasal pressure transducer prong comes out of the nostrils. The thermistor is gently detached from below the nose. The tape on the cheeks is removed. Patient breathes freely for the first time in 8 hours without sensors under their nose. They do not remark on this because they were not aware of the sensors while they were asleep. You remove the chin EMG electrodes with electrode remover wipes. These wipes contain a solvent that loosens the adhesive and dissolves the electrode paste. You apply the wipe, wait a few seconds, then gently lift the electrode. The skin beneath is intact. There may be a faint ring of paste at the electrode site, which the patient will remove when they wash their face. You remove the scalp electrodes. If collodion was used, you apply collodion remover, which is acetone-based, to the edge of each electrode. Wait for the adhesive to soften, and then gently lift the electrode away from the scalp. The electrode paste remains in the hair at each site. This is unavoidable. The patient's hair will require washing. You remove each electrode, F4, C4, O2, F3, C3, O1. You remove M1 and M2 from behind the ears. You remove the EOG electrodes from the face. You collect all electrodes as you remove them, placing them in a labeled container for cleaning and sterilization, according to your facility's infection control protocol. Reusable electrodes are cleaned, inspected, and re-prepared for subsequent studies. Disposable components, such as the ECG electrode patches and the leg EMG patches, are discarded. You hand patient A a warm, damp towel for their face and direct them to the shower. You explain that the paste in the hair is water-soluble and will come out with normal shampooing. This is true, though it may take 2 rounds of shampooing. You do not mention the 2 rounds. 1 round usually suffices. While patient A showers, you strip the bed linens and place them in the soiled linen bin. You wipe down the head box with an approved disinfectant wipe. You coil the electrode leads and return them to their storage. You wipe down the hard surfaces in the room with disinfectant. You remake the bed with fresh linens. By the time patient A has finished showering, dressed, and collected their belongings, the room is already being reset for the following study. You discharge patient A with a brief explanatory note that the study data will be reviewed by a sleep physician, that they will receive a report from their referring provider within a specified number of days, and that they should not attempt to drive if they feel significantly impaired by sleep deprivation, which given their history they may. Patient A thanks you. You acknowledge this. Patient A leaves. You proceed to patient B's room and repeat the process. Both patients have departed. The rooms are in various stages of reset. You return to the monitoring station. You complete your technical notes in the recording software. These notes will accompany the raw data to the scoring technologist and ultimately to the sleep physician who interprets the study. Your technical notes include study date, patient identifiers, referring physician, type of study, start time, lights out time, lights on time, total recording time, any technical issues with equipment or signals, any interventions performed during the night, notes on patient behavior or sleep behavior that were directly observed and are clinically relevant. For patient A, you note, lights out 10 p.m., sleep onset 10:17 p.m., sleep latency 17 minutes, total recording time 8 hours. Multiple obstructive respiratory events were observed throughout the night, most prominent in the supine position and during REM sleep. SpO2 nadir 82%, observed at 5:15 a.m. during a prolonged obstructive apnea in the supine position. Periodic limb movements observed beginning at approximately 3:51 a.m. No significant EEG abnormalities. No parasomnias observed. Study technically adequate for scoring. For patient B, you note, lights out 10 p.m., sleep onset 10:58 p.m. CPAP titration initiated at a starting pressure. Pressure adjusted once to the final therapeutic pressure during the night. At this final pressure, no further obstructive apneas were observed. One mask leak episode, briefly managed. Patient tolerated mask throughout the recording period. Study technically adequate for scoring. Recommended therapeutic pressure documented. You export the study files to the appropriate server or storage medium per your facility's protocol. You verify that both studies are accessible and correctly labeled. You submit them for scoring and physician review. You complete the room resets. Both rooms now have fresh linens, clean surfaces, and restocked supply trays. They are ready for the next night's patients. They look exactly as they did when you arrived yesterday evening, because all rooms must look exactly as they did when you arrived, because the patients who arrive tomorrow night should have no evidence of the patients who were here tonight. Each study is its own contained event. Each patient sleeps in a fresh room. This is a regulation, and also, in a broader sense, a courtesy. You complete your shift handoff documentation, noting any equipment that requires attention, any supply items that are running low, and any matters requiring follow-up. There is nothing unusual. Both studies ran as expected. The equipment performed as expected. The patients slept as expected, or in the case of patient A, slept, as their sleep disorder allowed them to, which is to say repeatedly and involuntarily, with assistance from nothing but their own compromised physiology, until you have now produced a detailed record of precisely how compromised it is, which is what you were there to do. You log out of the recording system. You gather your personal belongings. It is 7:08 a.m. You leave the laboratory. You have completed an overnight polysomnography shift. During this shift, you applied across 2 patients approximately 46 electrodes and sensors, initiated and verified 2 separate recording systems, managed 1 CPAP titration, resolved 1 mask, leak logged 1 significant SpO2 nadir, identified periodic limb movements in 1 patient, observed and documented multiple full sleep cycles, including all stages of NREM and REM sleep, completed 2 biocalibrations, 2 setups, 2 teardowns, and 2 complete sets of technical documentation. You drove home or took transit. You went to bed. It was morning. Outside your windows, the daylight was consistent with morning, because it was morning, which is the time of day when most people are beginning their days while you are ending yours. You slept. Your sleep was not monitored. No one placed electrodes on your scalp or belt sensors around your chest. No one watched your EEG cycle through N1, N2, N3, and REM. No one logged your SpO2 or counted your sleep spindles or measured the duration of your REM periods. You slept without documentation, which is how most people sleep, and which is fine. If you would like this to happen again, there will be another shift tomorrow night. The patients will be different. The procedures will be the same. The chair at the monitoring station will be the same chair. The coffee will be approximately the same coffee. The signals will scroll from right to left at the same pace, because that is the direction the recording software scrolls. And that is how you have come to understand time in the quiet hours of the morning, as signal traces moving steadily to the left, marking what happened 1 30-second epoch at a time. Thank you for watching. Good night.